I've chosen the title on purpose because this is a talk about living with MEN2. And so this is a philosophical bit to start with. The way I've been taught to practice medicine may be different to some of the styles you've gotten used to. I'm not saying mine's better, worse, but it might well be different. When I'm looking after someone with a long-term condition, which is what the name on the tin says, I'm going to be looking to look after people or help people look after themselves. And that's going to take place over some 10, 15, 20, 30, 40 years. This is a long journey, right? When you're going on a long journey, you got to get your kit right at the beginning, and you got to be prepared for a long journey. And the way I prepare people for long journeys when they've got long-term conditions is that I try to make sure that they know as much about it at some point as I do. Because that's the only safe way to be. The dangerous time for people with long-term conditions is when they meet a doctor or a nurse for the first time and they ask, what's wrong? And you go, I've got MEN2. And there are two times to be worried. Right? One is when they go, oh, I've never heard of that. Yeah? And you might think that's the most worrying. Right? Yeah. Actually, the person you've really got to be worried about is the one that says, that's interesting. So when I say the only way that you can be safe is to know as much as I do, it's not just the knowing about the condition, it's the knowing how to get what we need from the people we interact with. Yeah?
I know as I need, I just take me 2 tablets.
Yeah, that's right. So you found a way of getting what you need. So maybe over the next few years, it's not just going to be about learning about MEN2. It's learning how to navigate through what can be a very complex health system, so you get what you want. Yeah, and I think that's right. So this is really about being able to get what you want as well. And today might be about knowledge and information about the condition, but next time it might be about how to negotiate what we want so we get it. Yeah, that's like skilling people up. So this is what we're going to cover. There will be questions at the end. What it is, why it happens, and what are the challenges for moving forward. Yeah? Because you don't need me to tell you we might not have it right at the moment. We might be able to get things done better. This is one of the first people I met with MEN2. This is Alison. Alison presented, we call it in medicine, was discovered to have MEN2. When she arrived, and within a week of coming into hospital, we discovered she had all of those things all at the same time. Right? Not one, then another, then another. It's like full house right from the beginning. Yeah. The most important thing in Alison's life when we met wasn't actually that, or that. The most important thing in Alison's life was, I want to have a family. And that was clash number 1. All the doctors and nurses wanted to talk about this. Alison didn't tell anybody about this. It was like that Bill Clinton moment. We didn't ask her. She didn't tell us. Right? Right? The most important thing for Alison was this. The most important thing for us was that. The calcitonin test. Right? Alison had calcitonin tests. She had her thyroid taken out shortly after we met. And this is what happens to her calcitonin. This was year 2000, actually. Calcitonin went up. She had another operation on her neck then. Calcitonin comes back down again. Alison had and lives with a long-term condition. She knows what the monitoring is. She knows what we're going to do when something changes. She knows what the options are. And she knows when she has a problem, she can call. If she's worried about something, we don't wait for the year's appointment to come up. We see her when she needs to. We call this in our clinic, she's on a very loose rein, but it's a very short one. She can get what she needs from us when she needs it, but we have a regular planned in activity. What about this then? Alison and her husband put off this because the real question underlying that we didn't address was her and her husband's concern was, will it be different for our kids? It's like every parent's thought, actually, will it be different for who comes next? And two things to take from this. One is doctors and nurses don't know what patients are worried about, and they can often drive the agenda, and we can often miss what's really important to the people that we look after. And the other is, we're going to revisit this as this talk goes on. Because when I told Alison I was going to come to talk today, she said, well, what we want to look at as years go by to see if things are getting better is answer this question. Will it be different for other people? And tell them how it will be different for other people, so they can make their own mind up whether that's true or not. So we'll revisit this a little bit over the next 30 minutes. Will it be different, and how? Not just for Alison's children, but for the people who have MEN2 in the here and now. What's MEN2? So this is when the doctor says, never heard of that, right? You say it's an autosomal dominant inherited condition. This is the record you have to play. It's an autosomal dominant inherited condition, characterized by a problem in your thyroid, this difficult word, yeah? Problems in parathyroids, and problems with pheochromocytoma in your adrenal gland. So whenever someone says, I don't know what that is, you're at least as bright as our third, fourth, fifth year medical students, and they all say, MEN2. It's an autosomal dominant inherited condition characterized by the development of MTC, parathyroid problems, and pheochromocytomas. Tick. Right. Now go. Expert patient. They still haven't asked you what you're worried about, by the way, but at least they now know that you know what you've got. Yeah? There are other non-hormone related features as well that people can get. They can get problems with their skin, big brown patches. They can get neuronal problems with MEN2b or MEN3. And you can get musculoskeletal problems with kyphoscoliosis, bent, curved spine in MEN2b too. That's what it is. Style problem again, just for a minute to take it out. This is what the condition is. Doctors and nurses shouldn't be interested in the condition. They should be interested in the person who's got the condition. So for the geeky people, and this is for the young people, this is going to be what you're going to be tested on, okay? It's got one name, but there are 6, and I don't like this term, diseases. It's like when you unpack it, it's a bit more complicated than the one name. Most common is MEN2a, with medullary thyroid cancer, pheochromocytoma, and hyperparathyroidism. MEN2a with cutaneous lichen amyloidosis, that's the brown patch of skin. MEN2a with Hirschsprung's disease. We're going to be talking about bowel problems later today. MEN2b, wait for it, or not to be. Right? Yeah, I know, dong. MEN3, yeah. The same, but without the hyperparathyroidism. There's this thing, familial medullary thyroid cancer, which is what it says on the tin. You just get one problem, but you don't get the other two. And then you can get the same thing with Hirschsprung's disease. So one label, but those of us who work in big units recognize that there are different types within it. How does it happen? So we're going to talk about genetics for a minute, yeah? The first time I told this talk, and there was a teenager in the audience, I said, you've got MEN2 because you've inherited a gene from your dad. And he said, I'm never going to get any genes from my dad. I said, no, you've got to get 50% of your genes from your dad. I said, I'm never going to wear my dad's jeans. You haven't seen them. Right? So there's a gene on chromosome 10, and it's called RET. And that gene's got 22 bits of code in it. And it makes a protein called RET. And that protein's made up of 5 bits. These 2 bits here stick up from the outside of the cell. These 2 bits here stick on the inside of the cell. Because RET is a protein that sits in the cell membrane and signals. This bit receives the signal, this bit transmits it, like a switch. And the problem with MEN2 is that while normally this switch can be turned on and off in response to what's going on around, in MEN2, the cells that express this protein on the surface, it's switched on all the time and it can't be switched off. And in genetics, we call that a gain of function mutation. A switch that can be switched on and off in response to what's going on, it's switched on all the time. This is the bit with the moving parts, okay? It's a beautifully designed switch, is RET. It can sense, it can turn on, and it can turn off. This is like an automatic light switch. When you walk into a room, it senses the movement, and in response to that, the light comes on. When you go out the room, or you stop moving, the light goes off. One of the problems with beautifully designed systems is what happens when they go wrong. What happens when the light doesn't come on when you walk into the room? Waving your arm around, there's nothing happening. Yeah? Or what the Yorkshireman in me is really worried about, because it costs money, is what happens when the light's on all the time, even when you're not in the room. Yeah? And the problem in MEN2 is that the RET light switch doesn't care whether you're walking into the room or not. The light is switched on. It's sensing as though you're there, even when you're not, and it can't be switched off. That's the cell membrane. Imagine this on your adrenal gland. Okay? This is a cell in your adrenal gland. And there are these proteins sticking out of the surface of that cell. These rep proteins. You need to look at this blue blob at the beginning, at the end of it, because that's switched off at the moment. It's not active. But they're sat there waiting for things to happen. And the things that switch on these rep molecules are these purple things. That when something comes along and sticks to them, they come together. And when those two things come together, they make two rep protein molecules stick to one another. And something fundamentally changes when two rep proteins stick together. The shape of those two things at the bottom changes. And it switches on something on the inside of the cell that triggers something to happen down. Yeah, that's like it sensed you coming into the room, a mechanism has turned and the light switch has come on. It can also sense things in a different way. It can be switched on by those two proteins sticking to each other when they're not on the cell surface. But the same thing then happens. Senses, something changes, interacts with something else, the mechanism turns, the light switches on. But instead of a light switching on, what happens is that the inside of that cell is told to grow, divide, do your stuff. Yeah. And the processes that normally tell the cell to stop doing that, you're big enough, we've got enough of you, are switched off. Yep. So this is a really powerful, beautifully designed system. Yep. But in order so I don't get an extortionate electricity bill, yeah, I need something to switch this off. So just the same way, so your cell doesn't get told, grow, don't die, grow, don't die all the time. When you've got something as good at it as this is, it's important you've got something to switch it off as well. Yeah? And the thing that switches it off normally is that just falls off, the two rep proteins come apart, and the signal process goes away. The light goes off when you go out of the room. Yeah? You don't need to be a rocket scientist then to figure out something's going to go wrong if this doesn't operate normally. And that's exactly what happens. In MEN2a, those proteins come together and are switched on even when the two purple things aren't around. So that's like the light switch thinks that you're in the room and it's come on even when you're not. In MEN2b, MEN3, the proteins don't even have to come together and the light's switched on. So again, it believes you're in the room, it believes that you're moving around, and it switches everything on, and it never gets an error signal that you're not really there. But instead of a light being on all the time and me getting a big electricity bill at the end of the week, what happens is that the cells on which this protein's stuck, in your thyroid gland, in your parathyroid glands, and in your adrenal cells, instead of the light being on, it means the cells are permanently being told to grow and divide, grow and divide, grow and divide. And that's going to lead to a problem over time. And that's what MEN2 is. Now, when we do that experiment in a test tube, we make the same mistakes in the rep protein as occur in patients with it. We can get how good that switch is at being on all the time. And we can also tell how good it is at making cells grow. and we can recreate in a test tube the problems in the rep protein that occur in each different individual with MEN2. So this is about, well, how good is my switch at being on all the time? How much is it turned on? Have I got the dimmer down? Is it just a bit up? Or is it full on? Yeah? Is the light full on? Yeah? Well, there's a range. In the absence of the trigger to come on, some people's light's full on. If you've got MEN2b or MEN3, that light, it's like it's not just dimmed, it's like full on bright. Yeah? And for all the other genetic changes we get in RET, it goes down a little bit. That actually means, if you look at this side of the graph, that means that if you've got the RET protein that occurs in MEN2b, not only is it very active in a test tube, but it's really, really, really good at making cells grow and divide. Yeah? How does that help? Well, it helps because if you've got the light switch on really bright all the time, we know you're going to run up a big electricity bill really quickly. And if you've got the light switched on a little bit, we know it's going to take longer. If you've got certain changes in your rep protein, we know your cells are going to grow really, really quickly, soon. And if you've got other mutations, other changes, we know we've got some time before there's going to be a problem. Because over decades and over looking cooperatively across lots of countries, we can now see that depending on what spelling mistake you've got in your RET gene, you're going to get a problem with your thyroid either as a very young child or as an older one or as an adult. Yeah? We know if you've got the MEN2b change, you're at risk of getting a problem in your thyroid dead quick. Yeah? Because the light's on, full. But if you've got some of the other changes that we see in MEN2b, you don't get a problem till you're a bit older, or like dead old when you're 19. I remember thinking, that's really old, right? Doctors see age in a really unusual way. Anyone younger than them is young. Right? So if you were to design now, you're going to take a step from the test tube to the clinic. If you were going to take now a step into how to develop a service, you might go, actually no, this gives us an opportunity to do something really cool. What about, rather than waiting for someone to get a problem with their thyroid, because we know it's going to happen and we know roughly when, why don't we take the thyroid away so they never get a problem? Why don't we do prophylactic surgery? And that's what we do. We talk about risk levels. If you're in this group, you need your surgery as soon as we found out. Yeah? MEN2b, we want this done as quickly as possible. Risk level 2, you can have surgery under 5. Risk level 3, you can be really old when you have surgery. You can be 20. We know that you've got time, and we can plan it. And we can discuss with people when this is going to happen. We can discuss whether you want to go on holiday or not, whether you're going to do it before your GCSEs, when you're going to do it before you go to university. It's about having a conversation with people so it fits in with what's going on in the rest of their lives. And if we don't have that conversation, we're going to do the wrong operation at the wrong time. So, are things different? Alison's question, will things be different? One of the great things about working where I do, and I'm going to have to come clean in a minute because I'm not going to be working there for very long, I'm emigrating to Lancashire. Right? It's a long way. My dad would kill me. I mean, really, you have a problem. Is that I get to meet not only young people, but I get to meet their parents. I even get to meet their grandparents. And I have like 3 generations coming to clinic. It's like the Jeremy Kyle show. It's terrible. So this is Mildred. I first met Mildred when I first came to Newcastle after I'd been in Boston. She's in her 80s. And she'd had pheochromocytoma and medullary thyroid problems too. Mildred was married. She had 2 children. And I met Maureen. And Maureen had a medullary thyroid problem too. Yep. Maureen had a son called Philip, who we discovered the genetic mutation in for MEN. And Philip, we had to have a conversation with Philip's parents about whether he was going to be the first person to have a prophylactic thyroidectomy in the north of England. I don't know whether it was in the UK. It might have been, but we weren't really racing because it was about Philip. Some of you in the room will have been through this conversation, so rather than me tell you what it's like, we've got Philip's dad. It's always hard to be the first person, and it's always hard to be that first person's dad. And I wonder, in retrospect, what it felt like when we started talking about doing a genetic test and giving a black and white answer rather than what we'd done in the past, which was to have these blood tests every year. Did you feel under pressure? Or did it change things?
Well, I wouldn't say we felt under pressure. I think, I mean, obviously, my wife and her mum had the problem, and I think my wife knew the problems that would lay ahead. So yeah, we sat and discussed it, and basically there wasn't a problem at all, really. Obviously, if it was, you know, it was some sort of something new that was going to be tried, that was going to, let's say, help Philip in later years. So it was sort of a case of yeah, let's go for it, let's try it.
Okay.
There was no, I don't think there was any. I don't think we were frightened of anything in any way. I think it was just a case of with my wife. Yes, I've had the problem. I know what I went through. I know what my mum went through. Let's see if we can do something for Philip before he needs to go through the same thing, basically.
Sure.
So really, I suppose from a parent's view, more than Philip's view, there was no sort of like there was no question that he would have the operation done, because obviously, as everybody knows, as the saying goes, prevention is better than cure. And we just didn't want him to go through what Maureen had gone through, what our mum had gone through. And as I say, we explained this to him, and for all he was only 8 years old at the time, I think he understood.
I think he understood too.
Yeah.
That's fantastic. Thanks very much. So I'm going to stop it there because we're running out of time, and there's someone else I want you to meet who's going to talk about what it's like as a young person having all of this done. Okay? So we already know what the tests are that we have every year. You've been there, you've done that, you've bought the t-shirt, you don't need me to tell you. Okay? But this is coming back to this idea that MEN2 is a long-term condition. And when you're on a long-term condition journey, you need to get kitted up. And the only way we can kit people up is to understand from the patient's perspective what it's like going on the journey, not from the doctors and the nurses' perspective. And it's the patients we need to listen to more, because they've been there and done that and bought the t-shirt, and they can tell you exactly what you need to go on this trip. So I'm going to introduce you to an old friend of mine called Chris, that Joe knows. This is going to be difficult for me. And Chris discovered that he had MEN2 at the age of 11 and had to come into hospital and have tests and operations done. So now we're going to hear Chris talking about what it was like as an 11-year-old from the perspective of when he's much older.
I think there was a definite lack of understanding on my part as to, firstly, what the thyroid function was and how it was going to affect me directly. I hadn't been ill often, let's put it that way, and I think my first experience of hospital was a bit daunting, and it was discovered in such a way that it was a complete surprise. In fact, it was actually my father who said that there may be a problem that needed further investigation, and I could be asked to go into hospital fairly soon. Right. So it was a bit of a shock from that angle. And at 12, 13, or 11 or 12, whenever it was, I had no sort of real idea about exactly what that would involve at that point.
So he came to hospital, and it's like, so how did doctors and nurses interact with an 11-year-old to explain what's going on? Did he really get the care that we would like him to have?
The tests in the lead up to the operation were in many cases worse, because I think you don't know what's going to happen with those tests. You come in and you don't appreciate what an MRI scan is, what a CT scan is, and some of the tests at the start of the process were very much a case of, well, exploratory. It was, there may be a problem with your eyes, so we need to check them. So I tripped around the hospital for probably 3 or 4 days prior to having the news that the thyroid needed to be removed. And in many ways that was actually worse, because you don't fully understand what's happening at that point. At least when I was told that the thyroid needed to be removed, I knew pretty much what to expect. It was a 4 to 5 day stay in hospital. And in many ways the operation itself was probably easier than the tests, because it was sort of probably more of an understanding from my angle as to what was going to happen at that stage.
So that's really important for doctors and nurses to hear. It's not about the operation, it's about the build-up to it. But Chris had a long-term condition. He had his thyroidectomy, and I continued to look after him. When he moved away from Newcastle, he would come back and have tests. And at 27, we discovered he had not just one pheochromocytoma, he had 2 pheochromocytomas. So this is now what it was like going through that thing as a 27-year-old rather than an 11-year-old.
This wasn't a surprise at all. It had always been explained that once the thyroid had been taken away, there was the annual monitoring, which was fully understood. There
Sure.
was the thyroxine replacement, which was fully understood, and there was also this possibility that and hence the reason for an annual review, that a pheochromocytoma would appear. And I guess I was hoping in my heart that really that I was one of the statistics of people that it wouldn't ever surface in.
Sure.
However, I guess 2 to 3 years ago, I remember one of your letters saying that there was an elevated level in one of the bloods which suggested it was possibly a pheo. And at that point, I guess I thought, well, okay, this is a possibility. Let's hope it's an unusual result. But the reality dawned as more and more blood tests, as we did them in more of a regular frequency, came along those lines, that it was pointing to something amiss. And I guess that's a major difference, is that when I was young, I guess I didn't really know what was coming.
Right.
Whereas this time round I was fully in the picture, and aware of what was going to happen. And when surgery was inevitable this time round, then I was very much of the opinion, let's do it. I guess as a kid I would have been like, well, at that time I was probably more akin to saying, well, I'm not ill, why should I have this done? And you know, had to rely on expertise from you guys to say, well, you know, you aren't ill, but it needs to be done. And so there was a big difference this time round. But there's no doubt that this time round my age and sort of what I've been through in the past helped me deal with surgery this time round, which was really, I wouldn't say a doddle, but it was certainly a lot easier than it was last time round.
I'm just going to finish because I can't say any more than Chris can tell you. We've still got some work to do together. We need to make sure that the tests we do are accurate and reliable and everybody gets access to the same things. It doesn't matter where you live, you should get the same level of care. The only way we can do that is to cooperate and share information between centres so that we get better at understanding what's normal and what's not, what we can do and when we should do it. And we need to understand a little bit about the influences that say when people get the condition, not just what the genes are. I think we've talked a little bit about what MEN2 is, why it happens, some of the challenges that we've got. I'd like to thank the people I've worked with in Newcastle over the years in this. Paul Brennan is our clinical geneticist. Tom Leonard is our chief surgeon who does all the prophylactic thyroidectomy. Tim Cheetham was our paediatrician. He had to do a really unusual thing for a paediatrician. He had to let an adult physician, me, into paediatric clinics. And that was an unusual thing for a paediatrician to do. Bob Peaston is the guy who developed all the blood tests that we have in Newcastle. Sister Margaret Mill actually really runs the show. I just turn up, but she actually is the chief cook and bottle washer. She runs it. I'd like to thank MEN2a over the years because they've really helped us develop what we think is a reasonably good service in Newcastle. And the patients, their families, and all of whom, because I look after these people for, it's a long time. So I should have stopped being their doctor a long time ago because they're more like our friends, because we know each other so well. I'd like to thank you for your time too. Thank you.